From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to this podcast from JAMA Cardiology. I'm Bob Bonow at Northwestern University, Editor-in-Chief of JAMA Cardiology. And I'd like to welcome you to what I think is going to be a very interesting and important discussion regarding exercise and exercise recommendations in patients with hypertrophic cardiomyopathy. With me today are three very distinguished and well-published authors who have published a paper in JAMA Cardiology on this topic. So with me today, I have Dr. Rachel Lampert, who is the Robert Berliner Professor of Medicine at Yale University School of Medicine, where she is a clinical electrophysiologist. Welcome, Rachel.
Thank you, Bob. I'm so happy to be here.
And also joining us today is Dr. Sharlene Day, who is the Presidential Associate Professor of Medicine and Genetics and Director of Translational Research at the University of Pennsylvania School of Medicine. Welcome, Sharlene.
Thank you so much, Bob. Really delighted to participate today.
And rounding out our distinguished panel is Michael Ackerman, who is a genetics expert at the Mayo Clinic, where he is the Windland Smith Rice Cardiovascular Genomics Research Professor. Welcome, Michael.
Thanks a lot. Great to be with you.
So you three have headed up a really important study of exercise in patients with hypertrophic cardiomyopathy. And, I've grown up with the recommendations that most cardiologists have been following regarding exercise restrictions. So this is an important study with, I think, important ramifications. Sharlene, perhaps you could start this discussion by giving us a background of how these recommendations have evolved over the years up to date.
Sure, I'm happy to kick this off. The motivation for the LIVE-HCM study was to address a really long-standing question, as you said, Bob, of whether the level of physical activity, including engagement in vigorous exercise and competitive athletics, in individuals who have hypertrophic cardiomyopathy influences their likelihood of experiencing a potentially life-threatening ventricular arrhythmia. And because there's been so much uncertainty around this question, US, European, and other guideline documents across the globe going back really 40 years had been recommending that individuals with hypertrophic cardiomyopathy be restricted from participating in vigorous recreational activity or competitive athletics, citing concerns for their safety. And these concerns were legitimate, but were derived largely from retrospective and autopsy series in which HCM was identified as a leading cause of sudden death in young individuals, including athletes. That number started out around about a third of cases in earlier studies, but in more contemporary studies has been more in the range of 4 to 10% of all sudden deaths. These types of studies have many implicit biases, of course, referral and other. And most of the occurrences of cardiac arrest or sudden death occurred in undiagnosed individuals. And so while they've been informative, to the extent that they're relevant to the patient sitting in front of you has really been unclear. There have been a number of prospective series of athletes that have been emerging over the past 10 or so years, but many of these were on the smaller side in terms of numbers of individuals. Some were single center, and then some really didn't have matched control groups per se. So, the results from all of these studies collectively have suggested that the risk of sudden death may not necessarily be disproportionate toward athletes with HCM, but the need for more prospective data to inform decision-making between patients and their clinicians around these questions of exercise and competitive sports participation has remained. And that was really the primary motivation for LIVE-HCM.
Thanks very much, Sharlene. Yeah, this is important because many of us have kind of grown up with these recommendations as they have evolved or maybe failed to evolve to the current time. So, Rachel, as the lead author on this paper, maybe you could start telling us about the design of the study, how you implemented it, and then we can get into the results.
Thanks, Bob. So as Sharlene has said, our goal with LIVE-HCM was to compare outcomes prospectively and concurrently between individuals who are exercising vigorously, including those who may have been engaged in competitive sports, with individuals who were less active, either moderate or sedentary. And so with that goal in mind, we recruited and enrolled patients across the spectrum of activity who had been diagnosed with hypertrophic cardiomyopathy or who carried a gene for HCM without phenotypic expression, and that ended up being just 8%. So we identified these individuals. A total of 1,660 ended up participating. And we asked them at the onset of the study to fill out detailed questionnaires for us about their activity patterns. So we asked them both what they did and how many hours per week, weeks per year, et cetera, they were engaged in these activities. And we were then able to classify them based on a standard classification related to the number of METs associated with each physical activity into vigorous, moderate, and sedentary levels. We then followed these individuals prospectively over 3 years. And just to give a little more information about the recruitment, we invited patients through 2 avenues. We had standard recruiting sites. Overall, we had 42 sites across 5 countries. We had United States, United Kingdom, Canada, Australia, and New Zealand. And we also had self-enrolled patients, so patients who would hear about us through internet advocacy organizations such as the Hypertrophic Cardiomyopathy Association, other organizations, and contact us directly. So we then, in addition to having everyone fill out a questionnaire online about their activity, we also acquired everyone's records so that we knew their clinical picture as well. So we then followed them prospectively for 3 years, asking them every 6 months to tell us if they had had any of our pre-specified primary endpoint events, which included sudden cardiac arrest, syncope, which was later adjudicated to be arrhythmic, or for individuals who had a defibrillator, appropriate ICD shock. Our 4th endpoint was death, all-cause mortality, as well as sudden cardiac death, which we ascertained as well. So between the 6-month questionnaires and obtaining records from the sites and physicians, we then were able to determine their outcomes over the 3 years.
So just kudos to you and the other leaders of this consortium, Rachel, because first of all, you were able to enroll 42 sites representing high-volume hypertrophic cardiomyopathy centers, as well as free access to individuals who had heard about this particular study. And as I understand, this was also funded and sponsored by the National Institutes of Health because of the clinical importance of this topic. Okay, so now we have the backdrop, and we're all eagerly waiting to hear what your results were, Rachel. So give us the important findings of your study.
Thanks, Bob. So overall, as I said, we had 1,660 total participants. Of these, and just to give you a little bit of background, about 60% were male. They were divided by age between pediatric and young adults and adults. Age range was actually age 8 to age 60. So among the 1,660, 699 or 42% participated in vigorous intensity exercise. And of these, 37% participated competitively in their sport. So that's the group that we enrolled. And as I said, the vast majority, 92%, did have phenotypic hypertrophic cardiomyopathy. So we overall, 77 total individuals, or 4.6%, reached the composite endpoint. And when we looked at this, dividing the group between comparing the vigorous to the non-vigorous, there were 44 in the vigorous group, which was 4.6%, and 33 of those in the non-vigorous group, which was 4.7%. Pretty close to equal. When we looked at Cox regression, the corresponding rates were 15.3 and 15.9 events per 1,000 person years. So when we then looked in a multivariable Cox regression, we found that, as the number suggests, individuals engaging in vigorous exercise did not experience a higher rate of events compared with the non-vigorous group, with an adjusted hazard ratio of 1.01. This analysis was set up as a non-inferiority with the hypothesis that the vigorous would not have a higher risk of events than the non-vigorous. And so we found the upper 95% confidence interval was 1.48, less than our pre-specified boundary of 1.5. And again, the point estimate was 1.01 for the overall group. Now, we did look at some subgroups as well to see whether there were any subgroups within the larger group for whom the findings were different. We looked at those with overt HCM and found very similar findings. We also looked at the competitive subgroup and compared them to the non-vigorous and again did not find a difference. We then adjusted for some clinical variables, again, no difference. And even when we looked at those who were asymptomatic, we did not find a difference in event rate.
Really good data. And having had a chance to read your manuscript, you have a wealth of findings here that I think are worth pointing out. You have 40% women, which is really important because more and more women now are engaged not only in activities, but also competitive athletics. So the most important endpoints, of course, would be death or sudden cardiac arrest. Did that differ at all between any of the subgroups, including those who are competitive athletes?
We did not have enough deaths to look at them as an individual endpoint, but just looking grossly at the numbers, it was very similar.
Well, thank you, Rachel. Those are important findings. Another subgroup that's, I think, in our minds would be younger individuals because of our thoughts that perhaps teenagers, young adults might be at higher risk of cardiac events. How about varsity athletes in high school or college?
Yeah, we did look separately at the group between 14 and 22 years old, allowing us to capture high school and college varsity type athletes. And we compared that group to the other individuals of that age who are moderate and sedentary. And we found it was not a large subgroup, but we did find that we had 56 total varsity athletes of this age group, of whom 42 were phenotype positive. So those 42 varsity athletes with HCM did not have a higher rate of events than the moderate and sedentary kids of the same age. And in fact, they actually had a lower event rate. The group wasn't large enough for a meaningful statistical comparison, but I do think it's reassuring that the event rate in this group was numerically lower than in the other groups.
And how about differences between men and women in terms of outcome?
Interestingly, we found that among the arrests and deaths had all occurred in men, but the overall event rate, which included the ICD shocks, was equal between the genders. So I suspect we're not seeing a gender difference, but we're going to have to look at that more closely.
Okay. My final question, and maybe one that readers will pick up on too, is that these are all self reported levels of physical activity. Your paper does get into the fact that this is relatively well validated as a methodology, but perhaps you could explain that as well.
So I think in a large epidemiological study, whether you're looking at the general population or any population, the data that we have looking at exercise, vigorous exercise in general, is going to be based on self-report. And so we use similar types of methods to those that have looked at exercise in large populations. So I think we can feel pretty comfortable about this assessment.
Okay. So these are great data. And if the people listening to this discussion would also look at the manuscript, you'll see really how almost airtight this analysis has been because you did look at so many other sub-analyses. Let's bring in Dr. Ackerman. Mike, based upon these findings, where do you think the field needs to move now in terms of our recommendations and also our communications to physicians and to their patients?
I think, first of all, the observation is that this is an incredibly hopeful and hope-filled message that is a game changer. I think of back to when I joined Mayo Clinic's faculty in 2000. Really, the law of the land, the law across the globe was, if in doubt, kick them out. And with this well-intentioned goal of trying to prevent a tragedy of sudden death, I think the trickle down happened where we essentially sentenced families, individuals with hypertrophic cardiomyopathy to sedentary living. And as an unintended consequence, we sort of took away from our patients one of the most important medicines that we have. Exercise is one of the best medicines for the mind, one of the best medications for the body. And many of us rejected that approach and embraced now for 20 plus years shared decision making and wondered why we sort of created an exception clause to that approach in medicine of respecting patient and family autonomy and their right to make well-informed decisions. And we have been doing that for a long time at our institution. And I think now we see that this approach is perhaps generalizable. Of course, these patients really need to be cared for in centers that know HCM, deal with HCM, understand this disease and all of its nuances. But when we do that and when we sort of liberate people to live, I think the message that we see is that patients who exercise the most weren't at any greater risk than those who exercise the least. And it's probably time that we restore one of the most beneficial medicines that we have with encouraging our patients to be active, to exercise, and even the ability to exercise potentially at the highest levels of competitive sports so that in the future, our people with HCM If they are athletic, they will only be limited in the future by their drive and their discipline and not be limited necessarily by their disease and their diagnosis.
That's so well stated, Mike. I hope everybody has a chance to listen to those comments. Of course, regarding generalizability, these were generally asymptomatic individuals. You excluded individuals who had, overt symptoms, which would be important. So that's maybe another area for further research. But clearly, in this population of asymptomatic or minimally symptomatic individuals, the outcomes are really striking and important. I agree with you. I have patients I see who year after year tell me they're still participating in competitive soccer or ice hockey, and I've been always reticent to encourage that. And now, they'll be happy to know that I'm going to be supportive of their activities.
Yeah, we wanted to have our population be generalizable to the type of HCM patients who are making a choice about exercise. So, we really wanted to include people for whom exercise was within the spectrum of what their disease would allow them to do, as far as their clinical manifestations.
Well, this has been a great discussion. Perhaps let's go back to Dr. Lampert. Your follow-up thus far has been 3 years. And of course, we're talking about lifetime activities especially for the younger individuals in this study. Do you have plans to continue to follow these individuals and give us longer-term data?
Yeah, we really are hoping to do that. We're actually still following a number of the individuals, and we're hoping to reapply to the NIH for a long-term extension of the funding.
Well, you have my vote, and let's hope that you get support from the NIH to continue this really important registry. Prospective data such as these are going to be so important as we refine our recommendations and maybe even refine the guidelines in the future.
And Bob, what so far we've done and is super exciting is we fulfilled part one of the hypothesis, which was that those who exercise the most won't be any different or any worse than those who exercise the least. But the other part that we're studying right now is, and that those who do exercise the most will have a higher quality of life than those who exercise the least. You and I think we know the answer to that question, but it'll be interesting to see, did the patients themselves align with that expectation that indeed the active exercisers ascribe a higher quality of life than the most sedentary?
And I think too, we asked the patients about what their physicians told them about restriction. And so many of them reported having been restricted. Many of them were not following those restrictions. But I think understanding how that restriction has also impacted quality of life will really be important as well.
That's a very good point, and also helps to explain why you included those individuals who were gene positive but had a negative phenotype. Because the recommendations right now are those people should be able to participate freely in athletics until they have a phenotype turns positive. And yet you found that many of them had similar restrictions placed on them by their physicians. So that
Yeah, that was actually surprising how many of the phenotype negative individuals had been restricted. So,
yeah.
yeah.
Well, there, Bob, we opened the door with the American Heart Association in 2005, just like you said, that genotype positive only or a positive genetic test by itself would not be enough to disqualify you. But that position was not held in Europe. In fact, from 2005 to maybe just a year ago, a positive genetic test result by itself in Europe was disqualifying. And so maybe some of those in the disqualifying recommendation came from those European medical centers. And so I think the day of genetic discrimination, where we disqualify based solely on your genetic test result, hopefully that day is over.
So the other thing that we hope to do in longer term follow-up is to be able to follow a larger proportion or percentage of more competitive athletes at a higher level. The enrollment period during LIVE occurred when all of the guidelines recommended universal restriction, which we think these data no longer support. So our hope is that the enrollment of more competitive athletes, younger at a higher level, will become easier, as these data emerge and perhaps guidelines may evolve.
And in fact, Bob, we're very excited that in the United States, at least, ORCA has been launched. So ORCA is the prospective outcomes registry for cardiac conditions in athletes, where the intentional focus is on high school, varsity, university, professional level athletes with a wide variety of heart conditions, including hypertrophic cardiomyopathy. So this will be a very important ongoing observation to see and to make sure that this approach is not only the most healthy, beneficial approach, it's the right approach.
Well, that will be really exciting data as well. So as we follow the current cohort of individuals with hypertrophic cardiomyopathy and the broader ORCA cohort as well, really look forward to more kind of groundbreaking observations from investigators such as yourself. I'd like to thank these three leaders of the ALIVE Consortium, Drs. Lampert, Day, and Ackerman, for joining us. These are really important take-home messages for everyone. And I'd like to thank also our listeners for staying with us for these really groundbreaking messages. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Daniel Morrow at the JAMA Network. Thank you very much for listening.